Good evening, good afternoon, everyone. Thank you for joining us this evening. I hope you are all doing well in these times of the COVID, you, your families, and your teams. We are continuing our series of webinar by OVOGENE Egg Bank, and we will be talking today about morphological criteria for oocyte selection and how those criteria of selection of the best oocytes will affect the egg donation success rates. I'm Dr. Uliana Dorofeyeva. I'm the medical director of OVOGENE Egg Bank, and I'm practicing IVF doctor in Ukraine. I will be talking today a little bit, very shortly, about the donor selection criteria, just for you to understand all the process from the very beginning, because as the oocyte is really important and the most important, but it starts from the donor. And my friend is with me. It's Birol Aydin, clinical senior embryologist and the laboratory manager and lab director at IV Med Clinic in Kiev, and also scientific advisor at IV Med Clinic, our main supplier for the OVOGENE Egg Bank of the oocytes. So I know that I am the host right now, and I would like to share my screen and share a few slides with you. So regarding the donor selection criteria, what everything starts, our partners very often are asking us about how we do donor advertisement, how we recruit our donors, what do we say to our donors. I should say that in Ukraine, and Ukraine is a country where oocyte donation is officially legal, and it's done since 2001. And then I was in the practicing egg donation since that times. And this time, almost 20 years ago, those women, they didn't know what is to be a donor. And what we did, we educate them and we promote oocyte donation. Right now in Ukraine, we have more than 60 IVF clinics. All of them are private and many of them are recruiting egg donors. But we keep doing what we did for years. We keep educating our donors. We keep taking great care of them. And this is like in every market, in every activities. Everyone knows who is the best. So we are doing our best for our donors to select our clinics, best practices, trustable centers where they can be treated with the best care. Of course, we are doing online marketing. We are publishing the offers of being an egg donor in the magazines. But as I said, the most important is to give them the opportunity to learn more about the process, about like sometimes they are scared about some processes. So to answer all their questions and as I said, to treat them well. After we are receiving the initial call or the online form from our potential donors, we have initial interview and we are asking the most important questions like the age, the fact that they have a child, because in Ukraine, every woman should have a child who is going to be a donor, like the genetic status for them. They need to have information about their parents and grandparents, and we are filling very detailed profile. And also their medical status, their lifestyle. This is also important because those criteria are inclusion criteria and exclusion criteria for potential of being an egg donor. After we did that, we invite donor for ultrasound examination and the antral follicle count calculation. Our criteria to include a donor potential candidate into the donation is 14 antral follicles at least, and the IMH level, but we check IMH a bit later, is 2.5. After we checked all the gynecological status, and of course, no endometriosis, no myomas, no surgeries, laparoscopies on the ovaries, anything before that donation process. Then we do screening for the infections. And of course, if they are carriers of anything, we exclude them from the further process. After we did all that and all is right, we perform counseling by our egg donation coordinators. In every clinic, we have special teams of the specially educated people who are talking with the donors, and they are supervising them on all process from very initial interview until the last cycle of their donation, because they can donate several times in Ukraine, maximum 8. It is according to the to our regulations, but regularly we follow 6 as recommendation on ESHRE, but on request we can call them for a few, 1 or 2 more stimulation cycles. On that period, like during that visit and the consultation, where they also can ask all the questions, they are signing the agreement with the clinic and they are signing all the consents. As you know, we are shipping our materials into different locations, and this is the time now when we are talking that this is benefit of the egg bank to travel the materials, but not to travel the patients. There is no possibility to travel the patients, and this is also associated with the risk for their health, of being infected of the COVID, being treated and diagnosed in the different country with no insurance, etc. So I, as a practicing physician, was treating patients even last year from more than 30 countries. They all were coming to Ukraine, but now there is no possibility like this. But there is many, many opportunities to bring materials into the locations where patients are, and clinics may receive those materials and treat their patients locally. After we do the counseling and we have all the consents and the agreement, we do psychological evaluation, and this is very detailed report from our psychologist, and also the MMPI report and test result. After that, we do genetic counseling, including the patterns and genetic testing. Normally, for all, we do karyotyping, cystic fibrosis, Fragile X, and CF, the most common mutations for the European population. And also on request, we do, and quite many donors already have been tested for advanced genetic testing on the panels of about 300 mutations. After we did all that, we are going to the process of the stimulation. So donor is already approved, and we have our SOPs and protocols written, and this is on the quality management side, which dose, which medications we are going to use. Of course, we use only recombinant FSH, and we have dosage of the medications for the initial stimulation based on the age, weight, and the BMI and IMH of the donor. If this is not the first stimulation, we also consider the results of the previous outcome and the stimulation and the number of the oocytes, mature oocytes, and different key performance indicators. We do oocyte collection procedure, and on that time, we took the blood to get the DNA sample, and this is our great advantage because we are keeping DNA of all our donors in case anything will happen, and we all know this, that this is very, very little chances, but still this can happen for those who are not tested for the advanced genetics, or even if they are tested, but this is not the common panel, not the full exome. So we have the DNA samples. We have many key performance indicators, and this will be a topic of our next presentation, how we consider that the stimulation was effective from the medical point of view. Number of the received oocytes, percentage of mature and immature, degenerated oocytes, what is the optimal number, not optimal, but we do calculate all this and consider this for the further stimulation processes. And we have our software, this is EVSoft Fertility, where we control all the donor efficiencies. We have all reports, and we are really thankful for our partners to provide all this. Even if materials are sent to any clinic in any locations, we are asking to get the reports, and we are getting the reports, we are analyzing them, and we have exclusion criteria in case two different sets of the oocytes had survival or blastulation or clinical outcomes as we consider as non-optimal, and warming of those sets were done in 2 different locations. we exclude this donor from those oocytes from sending them somewhere. We evaluate the outcome once again. We talk to our senior scientific team and we decide either this donor should continue to be in our database or not. And we use oocytes locally if we have a need to use this, and we are evaluating the outcome. So this is very deep process of the starting from very initial consultation, as you saw, and also the clinical process. But we are going to talk about morphological criteria, and I would like Birol to continue, because as soon as we did the OPU and we received the follicular fluid and embryology, this is the heart of all our work. And I'm saying this all the time, and this is very important. So I would like Birol to continue about morphological criteria and all the efficiency connected to that. Thank you so much.
Thank you very much. Good evening, dear colleagues. So I need to share my screen. Can I get permission to screen sharing? Okay, yeah.
Just a minute, Birol, I'm changing you to the host.
Okay. So we are in. Okay, as you know, most of the egg bank, the priority is the survival rate. So when we send the egg for our customers or clinics, so of course we are our main target to get high survival rate. But as OVOGENE Egg Bank, so our target is not only the survival rate, but we want to give a good IVF outcome to our final clinic as high blastocyst rate, and only not a blastocyst rate, but an euploid blastocyst rate. So from this target, so that our aim was to create a technological database and technological software which will help us for morphological assessment. Because experience of embryologists like under microscope till somewhere. So still we are not able to totally determine like a size of polar bodies, size of Perivitteline space, Zona Pellucida. So we need a special technology for that to measure and to determine a high quality oocyte totally. So okay, mainly like for the oocyte, what is the importance? The spindle of the oocyte is responsible for pronucleus assembly and first meiotic division. So from that point, we try to manage before the vitrification to determine exactly location and also quality of the meiotic spindle. So DNA starts its expression on the second and third day of the development. So that's why cleavage rate is very important for the donor egg programs. So when we give the donor eggs, when final clinic thaw the donor eggs, we should totally avoid cleavage arrest risk, because it's the main point and main question for the frozen cycles. As you know, like oocyte organelles are responsible for the rest of the meiotic division. So that's why it's important cytoplasmic activity, mitochondrial quality of the oocyte, which we get such information from the donor history. We have the good clinical outcomes, which we keep in our software and database, and we are calculating that for each egg donor. And more or less, we know for all donors, for the actual pregnancy rate, blastocyst outcome, and also we know like a euploid and genetically healthy number of oocytes. Another important things like the oocyte parameters, which we are talking like how we can manage for the main measurement for the evaluation of the oocyte parameters. So like our system, which we are using artificial intelligence, which is connected to time-lapse system, So for the oocyte morphology, we are evaluating a cumulus oocyte complex morphology, Zona Pellucida quality, Perivitteline space, first polar body appearance, oocyte shape, meiotic spindle location, cytoplasmic granulation, centrally located granular area, and of course time-lapse activity of the oocyte. So when
I'm sorry, Birol, can you make a small break and accept the people waiting in the room?
Mostly I accept all. Yeah. Okay.
I'm getting the requests.
So I think I accept all, as my screen shows everyone here. There are first priority for us, cumulus oocyte complex. When we pick up the eggs, so we are checking as before the morphologically to assessment of the oocyte, cumulus oocyte complex. There are several articles which work about cumulus oocyte complex, and some of them didn't find any correlation between fertilization, cleavage, and clinical pregnancy rate and cumulus oocyte complex. But one of them find out like there are a direct correlation for the embryo development and blastocyst quality about cumulus corona radiata cells. So that's why when we make the egg pickup, mainly we are trying to avoid totally blood cell and a big cumulus cell from the oocyte previous denudation. Because if we have the high thickness of the cumulus oocyte complex, this directly will affect as a pathologically the quality of the oocyte and also quality of the cytoplasmic activities. Donor oocyte size and shape also for us very important. So how we are calculating this? This is which we work with, collaborate with a Nikon company, and we try to develop with them high quality artificial intelligence software which is working directly for the oocyte morphology assessment. So we are using a live imaging of the individual donor oocyte performing by Nikon dipod 300. This is a dynamic time-lapse camera which is working with a Hoffman optics and stain-free objectives. So there are already implanted on the system circular polarization filter, which is showing us the quality of the cytoplasm, and liquid crystal analyzer optic, which is calculating it directly concentration of the cytoplasmic activity. So that gives us a direct performance for the quality one oocyte, which we consider to take for the freezing process. So all measurements regarding size and shape, we are collecting on the artificial intelligence software, and from the different data collecting by the artificial intelligence software, and it's giving us exactly data which we need to use for the freezing protocol. So ovarian diameter of the metaphase 2 oocyte is approximately 100 micrometer. This is really important for us because mostly between metaphase 2 oocyte and giant oocyte, there are the critical phase which we need to decide to take this oocyte for the freezing protocol or not. So this is directly affectable for the fertilization and developmental quality of the ICSI technology. So if we talk about morphology of the first polar body, there is a strong correlation between morphological features of the first polar body and the fertilization rate and embryo quality. As you know, first polar body is directly affected to euploid or aneuploid rate of the oocyte. And from this target, also as OVOGENE scientific team, we developed genetically certified oocyte. So after the denudation, when we get the morphological assessment, which we find quality one oocyte, depends of request of the customer, of course, we have chance to analyze by the NGS technique, a polar body quality, and we find out already euploid oocyte. So that gives us a big advantage with high quality of the oocyte, which we will get most possible way to get euploid blastocyst and cleavage development. So that will give the advantage to patient if you don't use embryo biopsy or NGS techniques only for the embryo transfer. So we will already give you euploid oocytes, which will give a big possibility of euploid blastocyst. So there is direct correlation between the large first polar body and decreased fertilization, cleavage rate, and embryo quality. So if we talk about a Zona pellucida in the donor oocyte, so the thickness of the Zona pellucida should be not less than 15 micrometer or more than 20 micrometers. So this is also directly measuring by the artificial intelligence. As you know, like under the regular stereo microscope, there is no possibility to analyze that well. And thickness of the Zona pellucida, the next slide I will show, has direct effect somehow to fertilization rate and the cleavage rate. So the Zona pellucida has role for oocyte development, fertilization, embryo development, spermatozoa binding, blastocyst formation, and premature implantation, which is interesting because it's affecting directly ectopic pregnancy. So increased inner layer of the thickness was reported to correlate with increased blastocyst rate, higher embryo development rate, and clinical pregnancy rate. So how we are analyzing a Zona pellucida quality in the donor oocyte? While we are using a Meiotic spindle determination software, which is connected also directly to artificial intelligence, so we are able to measure exactly thickness of the Zona pellucida. So that shows us the maturity of the Zona pellucida with high zona and low zona. So we can determine the exact thickness of zona by this way. So what will bring us advantage if we do? So as you see in the graphs, so if we make the low zona and high zona difference, as you see, it's directly affecting the pregnancy rate and implantation rate. So when we have exactly thickness of the Zona pellucida, almost the pregnancy rate and implantation rate is really high. But when we have very low Zona pellucida thickness because of the towing quality, and as finally this is a traumatic method kind of. So when you tow the oocyte, the thickness of Zona pellucida is getting lower, and it's directly affect your fertilization rate. And mostly you may find like after ICSI degeneration oocyte. Also you may find a high quality, high fragmentation rate that is directly connected with the thickness of the Zona pellucida. So if we talk about the perivitteline space, which is also important for the donor oocyte, of course, for the quality one oocyte, this is one of the criteria which we are taking care of. So large perivitteline space correlated with the low fertilization rate and low survival rate after the towing. Also, when you have the increased perivitteline space, so it is most possible for the vitrification process, there will be more cryoprotectant concentration between olema and Zona pellucida. And when you tow the oocyte, mostly this oocyte will recover really late. So you will wait 2-3 hours, even it will not be enough for the fertilization, and possible damage will be during fertilization for high perivitteline space. So perivitteline space diameter measured by the algorithm of the artificial intelligence, how system is calculating. System is calculating by the Zona pellucida thickness and minus olema length. So when we calculate this, artificial intelligence automatically say us which oocyte we should get as quality one and to freeze for the egg banking. So appearance of the Ooplasm in the donor oocyte, we are using to calculate this because by morphological assessment of the embryologist is impossible to find out this exactly. So we are using a Nikon Diapod 300, the dynamic time lapse, which has camera with a liquid crystal analyzer optic. So optic is just catching the concentration of the cytoplasmic area and calculating like appearance of the Ooplasm, and is giving to us a black, white, high resolution with filter and which oocytes exactly need to be freezed. So if I share my experience, so I have a 10 years of experience for egg banking, and when we choose the oocyte, and mostly we believe this is the quality one because we are really trying as embryologists to choose best one. But after the work with artificial intelligence, I find out already 30% of quality one oocyte, which I'm thinking is quality one, by the artificial intelligence is getting the quality two categories. So if we talk about meiotic spindle determination, abnormal meiotic spindle affect the chromosome configuration and increase aneuploidy rate of the oocyte as the complex aneuploidy. So that's why we are trying to get meiotic spindle determination before the choose oocyte for the morphological assessment for the vitrification process. That is a priority for us to find out. Of course, that meiotic spindle determination will be also very important for the possible damage during the ICSI. As you see on the photo, like that image, meiotic spindle location is directly like a 3 o'clock position, which most of the embryologists would like to make ICSI process. So a possible ICSI process will give the traumatic damage to meiotic spindle, and this egg even will not fertilize or will not give the quality of the blastocyst and will end with the cleavage arrest. So we are trying to avoid this. That's why that depends on the request of customer. Actually, we are giving them like a high resolution of the time-lapse image where they will find exactly location of the meiotic spindle during ICSI, even if they don't have any kind of meiotic spindle software. So next slide, I will try to explain how without software you will find out from our image where you should done ICSI. So each donor oocyte we are observing before vitrification process and location of the spindle captured by time-lapse camera with local navigate the place. So for each donor oocyte we are doing that, but of course we are sharing with customer that depends of the request. So this is the like how we are giving information to our customers if they have requests. So when we take the real-time photo image and we just system is just making this graphic to you, when you put oocyte under the microscope, you find out exactly angle of the spindle, and it will be so easy for you to determine where is the meiotic spindle, and you will choose the place of ICSI according to meiotic spindle place. Also, if we test oocyte by the polar body biopsy NGS testing, mostly, of course, you will not see the polar body when you top the oocyte, and it will be crucial where is the meiotic spindle and how you will find where you should make ICSI. So in this case, as you see in the image, we already will show the place of the polar body on the time-lapse picture, and also we will show the meiotic spindle location. So you will find out where you should make the ICSI exactly. That will avoid all risk of the meiotic spindle damage and risk of low fertilization. So this is the way how we are trying to do meiotic spindle determination. So by each oocyte, even if they have a low morphological assessment, for us the main priority to find out the location of the meiotic spindle, because still 20% of the donor eggs, even if they are quality one, we are not able to find out the meiotic spindle after denudation. So we are avoid those oocytes for the freezing protocol, and we are putting them in Q2 categories. So finally, as main customers, which will order oocyte from the OVOGENE Egg Bank, they will find out all oocyte with the meiotic spindle. So meiotic spindle visibility increasing already fertilization rate during ICSI for the possible damage risk also. Meiotic spindle visibility decrease oocyte aneuploidy rate. Meiotic spindle anomaly direct effect has the blastocyst formation and embryo aneuploidy rate. A meiotic spindle size should be 19 to 100 micrometer predicted not only the higher fertilization rate, but also a higher blastocyst formation. So when we when we find out the meiotic spindle, we are not just find out only the location. Our software also measuring like size of meiotic spindle. So why this is important? I will show the next slide. So this is the typical when we try to tow oocyte and find out the location of meiotic spindle. And when we try to do fertilization by the meiotic spindle weave, as you see, like it will not have any kind of risk during ICSI, any kind of traumatic damage, because already we know the place of the meiotic spindle. So we, by this way, by this the time-lapse image, even if you don't have software, so you will be able to do fertilization without any kind of damage. So as you see, meiotic spindle outcomes. So when we determine the meiotic spindle and when we determine only polar body imaging, so there are huge difference because the total fertilization rate in one of them 65, another 78.5, almost like 15% of difference at higher fertilization rate. And number of embryos, if we check, 56 from the only polar body determination, but 84 high quality embryos and cleavage embryos on the third day from the meiotic spindle determination. So another outcomes when we see the good quality of the blastocyst rate. So when we measure the size of meiotic spindle, if it is less than 90, so as you see 20.8, when you have 90 to 120, so it is almost high. So our target to find more than 90 micrometer of the meiotic spindle. So when we find out that, we are getting this oocyte for vitrification protocol. So basically all this doing by the artificial intelligence, which we developed by the OVOGENE scientific team. So how system is working, system is catching a different oocyte image, because as you know, some donor giving 20, 30 oocytes, so all of them can be good quality by the embryologist weave, but still artificial intelligence need to understand which oocyte will choose. So when we put them under the time-lapse and time-lapse camera by the artificial intelligence software, just is capturing like a more than 100 capture. So it's just making a different measurement for the perivitteline space, a polar body, Zona Pellucida, olema. So all this data is collecting in the artificial intelligence, and on the end, we just get the final selection from the artificial intelligence. As you see, like even for the low quality of oocyte, when we put them in under artificial intelligence, system will show us the main defect where we have. So why we shouldn't choose this oocyte for freezing. So artificial intelligence system is calculating, as I said, the Zona Pellucida, cytoplasmic activity, polar body, perivitteline space, outer diameter of the Zona Pellucida, inner diameter of Zona Pellucida, also like a thickness of the Zona Pellucida directly is getting by the artificial intelligence. So light source is catching all the image, and then main calculation is starting with a different algorithm, and finally we have the all data in a one graphs, and we understand that from the system which oocyte has high potential for the freezing and high potential for the, let's say, for fertilization and blastocyst outcome. This is the basically how oocyte looks under the time lapse. Even it shows that possible damage on the polar body, possible damage on the Zona Pellucida and cytoplasma. So even if we work with a different embryologist, so each embryologist data is getting the main computer, and we are collecting in the main computer, and final decision is getting by the artificial intelligence. So, and when we get the exactly quality one oocyte, so we are doing the final determination on by the artificial intelligence under time lapse. Okay, like we are totally sure about the compact polar body, we are totally sure about cytoplasmic activity, Zona Pellucida and perivitteline space. Then we are ready to freeze this oocyte as quality one for the customer. So actually we are following a totally different way than other egg bank. So we are not just using it's kind of witness, okay, like many clinics are using only human witness. So, but most of the clinics start to use electronic witness, which is more trustable. So because the technology is controlling process well than human factor. So we are targeting the same way for the artificial intelligence. This is the basically set of oocytes which artificial intelligence decide to freeze. So as you see, all oocyte looks very fine, compact, and beat by all measurements. So even we are able to keep this data and videos to share with our final customers so they can be able to see how we are doing a vitrification process. So for the artificial intelligence, the donor oocyte selection, this is the algorithm what we are calculating. So this is only for one oocyte, what we are making a calculation for the diameter of oocyte, the diameter of Ooplasm, diameter of polar body. So that all data we are keeping for each oocyte. So when we talk about the 30 oocyte, of course, this is a big data, and you can think how we are managing this time, because like time is so crucial for the vitrification process, but actually artificial intelligence calculating that in a minute. So of course, still we can choose the best oocyte, we can use the high quality of vitrification techniques and everything, but when you thaw the oocyte, there will be possible damage, which will not affect the directly outcome, but you can see like a polar body degeneration or fusion. You can see membrane permeability is low, or Zona Pellucida hardening. So this is the typical quality 2 oocyte risk. But when you get the quality 1 oocyte, which is really quality 1, you will not see such risks when you thaw the oocytes. And survival rate will be high, of course, even if you are not able to get the exact condition in your lab, let's say like a temperature condition, pH condition. So quality of oocyte and like a strong part of the Zona Pellucida will protect the oocyte from the and other factors. So how we are keeping in our egg bank like a storage of the donor eggs. So we are using a mostly vapor technology. We are not using a directly liquid nitrogen technology, because vapor technology is a much more safety for the donor oocytes. It's keeping it like a down part and upper part almost in same temperature, and we are able to, with data logger, with SMS system, even if we are not on clinic, with a backup of the liquid nitrogen and backup of the battery, we are controlling the whole system. So how we are doing cryo storage tank control during egg banking. So we are using for that because we are talking about many donors, many donor eggs, 1,000 of the eggs, maybe in a month, more than 1,000. So how we are controlling in the storage, because still it is crucial when we load this egg to final customer, we should find out very carefully to don't give them any damage during the loading. That's why we create for that a tank control system, which is automatically connected to witness system. So all egg donors are going to electronic witness system. And this electronic witness system, which we are freezing all cryotopes or straws by the RFID chip, so automatically release or give us the map on the cryo storage. So when we try to take one oocyte, we know exactly placed by the witnessing system. So this is the how we are labeling a straw. So we have RFID chip smart, we have high quality of labeling, which has high resistance of the liquid nitrogen. So as you see in cane and visotube should be loaded during the transport and plus with the sleeves. And also, as you see, like labeling should include a donor code, unique donor code for the egg bank, number of the quality 1 oocyte in the each straw. So we are freezing only option 2 oocyte in each straw or 3 oocyte. So date of birth date of the donor and date of vitrification. So those donor oocyte packing and transporting is another important thing. So when we send the final clinic our donor oocytes, so we are marking them with exactly the donor code with the tag of the cryo, and we are sharing with all customer our mapping, our unloading instruction, and also when you receive the material, you will find the flash disk which shows towing process by the video, by the explanation, also unloading process by the explanation. So each shipper is coming to you with the data logger and the security box, also with the sealing. So this is the typical process how we are preparing for the shipment oocyte. Of course, firstly we are charging the shipper. We are using a quick charger of shipper, high quality one. So we are identified straw by the electronic witnessing system, but of course you will not be able to find out this witnessing system maybe in your clinic, but finally it will go out from our clinic by the electronic witnessing system. So isotype identification, cane identification, then we'll be loading the canister, sealing plastic ties, and packing a protection box, and will come to you by our hand courier. So how we are doing a traceability of the donor egg banking? So we are using electronic witnessing system and RFID system for the traceability. So when donor stimulation start, already IVF specialist put all information of the egg donor as a stimulation day, trigger day, and the possible punction day. It's already we find out in our witness system, appointment system, when we will have this donor. When donor come for the oocyte pickup, already she has on the reception a wristband or bracelet with electronic chip. So when she needs to enter the operation room, she's just reading the wristband, and she find out all information on each tablet and main screen. And each embryologist which is doing oocyte pickup also find out each tablet of the laminar flow, so all information about the egg donor. So finally, when we freeze the oocytes, we are able to have for each stroke RFID chip, so which shows exactly traceability of the process. Even we try to get some new way for that. So each customer who want to be sure about traceability for the electronic way, so only if they have the card reader, if they supply card reader, so as OVOGENE Egg Bank, we are ready to share our online software, witness software for the donor witnessing. So they will just take from us the straw with the RFID chip. They will have a card reader which is connected, which we will give a free of charge from our site, an OVOGENE site, a software. So they will just read the straw and they will find out electronic witnessing for the donor oocyte. So when they will just read the RFID chip, they will find out the code of donor, birthday of donor, so number of quality one egg which they receive, and vitrification date exactly. So this is the basically how a witnessing system is working for egg banking. So each embryologist have staff ID card. We are able to understand which embryologist make the all process. So patient is making all process by the patient wristband. So we have everywhere in the laboratory with the reader and writer. So each cryotope, each dish, before denudation, before punction, we find out the witness by the electronic way, and all data keeps on tablet and LCD and also our server. So by this way, we are totally getting traceability of the egg banking. So thank you very much for your time and for your attention. So if we have any kind of question, so I'm glad to share with you answer.
Thank you, Birol. It's great lecture as every time. I think we will get more questions, but we already started to get some. And there is the first question from Dr. Pascalini. Which factors of the donor do you think that can affect oocyte quality the most? Lifestyle, ovarian stimulation. If you have poor quality oocytes, what do you suggest to check? The donor, the ovarian stimulation, lab conditions. How do you stimulate your donors? So I would suggest that we would divide this into the parties, and I will start from the medical side. And this is really great question. This is the question which we are asking us the most commonly probably. And this is true that this can be related to all of those what you just mentioned. Initially, this can be a donor, and we have a list of the donors which we are not stimulating after the very first stimulation, even if they are detailedly checked with the conditions of the genetic testing, etc. They provided all information about their status genetically, etc. Because their outcome for the stimulation is very poor. Not only in case of the number of the received oocytes, this is not the most important for us, but the quality of the oocyte, the morphological quality, and also the conditions, how they reacted into the medications. We already know that there are, even in the population of the donors, we have donors with the mutations of the receptors for the gonadotropins, so they can react differently on the regular dosage of the medications. Their stimulation can be really longer, and this is one of the factors. Also, very important factor, as I said, this is the morphological conditions. We also have this clinical experience of having different outcomes from several different stimulations from the donor. Let's say her first stimulation, we got wonderful outcome, nice morphologically assessed oocytes, good quality, clinical pregnancies, etc. And then the second or the third cycle, after 2 successful ones, we had very bad results. Also, the lifestyle is important, and we are checking all these all what they can get, like the drugs, the alcohol, etc. So we are controlling this really deeply. And this is the work of our medical coordinators, and they have relationships with the donors, so they do understand their responsibilities according to this. But and also, of course, and we had that experience with some clinical facilities where the stimulations was fine, the morphological assessment for the oocytes was also great, but the conditions in the lab and the performances of the embryologist were not optimal. So I think Birol will comment more about this.
Yeah, actually my experience shows, of course, that stimulation is the main factor because finally embryologists are working with the main product. So when we find the quality of oocyte after the denudation, even during oocyte pickup, more or less we understand from the cumulus complex quality if that oocyte will give really high quality of oocyte for the freezing or not. But even if donor given first 3 cycle really high quality oocyte, so this is a directly of like a strategy to continue to use this donor because really have high quality of clinical outcome and morphological assessment. But when we come to 4th cycle, that is surprisingly, we can find out a totally different picture. As Dr. Uliana said, of course, there are different factors. So finally, this is a human process, and like stimulation is working through the hormones. Many different factors may affect that, mainly, of course, a lifestyle. But when we find the oocyte in the lab, of course, from the embryologist side, is the most important things for the work with donor oocytes, especially timing. So timing is really important because from the triggers, if we are collecting egg on 35 hours, so we have to use this gap of the 3 hours till fertilization very actively. So if we have freezing protocol, so we should try to freeze as soon as possible. We can give us enough time for the final clinic, which will thaw these eggs and will wait after the thawing 2-3 hours till fertilization. Because still there are different issues can be happen for the fertilization. Maybe like a male factor will be affected and he will not be able to give sperm on the time. So then oocyte will wait much more. So we are trying to give the clinics much more time till the 40 hours so they have enough time for the fertilization. But mainly as lab side, much more important how to evaluate a morphological assessment if they really choose the oocyte well for the vitrification process. And secondly, of course, there are different factors which I talk about for spindle quality, for euploid oocyte rate, also directly affect the IVF outcome.
Right. Yes. Thank you so much. Also, there is a question very much related to the previous one. Do you think that the stimulation protocol can influence the quality of the eggs, duration, or dosage? So, answering also the question of Dr. Pascalini previously, we are using a short antagonist protocol with agonist trigger as a main protocol for all our donors, because this is safe and this is really reliable, and it's easy to navigate, to plan. It's easy to understand for the donor. We are not using the oral contraceptives anymore. Like, we did that and we stopped that experience almost for 2 years since now. So in case we need or we see that there was not synchronic growth, we can use pre-treatment like estrogens or pure progesterone, but not oral contraceptives. And this also impacts the results of the agonist reaction, trigger reaction. So the concentration and the number, the percentage of the received oocytes, mature oocytes from the follicles which were punctured is much higher without oral contraceptives. So this is probably the level of the LH and the sensitivity to the agonist triggering. Of course, the duration is important, but also the triggering time and the volume of the follicles, the size of the follicles once you are doing the triggering. So we are doing triggering on when the main cohort is 18. In case we have asynchronic growth, also we monitor this and we put this as a mark for our process in the software. And this we trying to avoid this in our next stimulation for the same donor. Doses, we never overstimulate our donors, but also like the minimum is 150. We never use 100 units gonadotropins because the recruitment will be really low and then the stimulation will be much longer. But the average is between 150 to 200 because this is a group of the good responders. We will talk more about the stimulation protocols for our donors because this is really a multifactorial and complicated and not for just answering the questions, but for the full presentation. So, and we will continue our series of our webinars and I will tell definitely more with some clinical cases, what we do accept, what sometimes happened, what we can avoid and how we do that. So it's for another our talk, but if there is any specific question, please ask. There is another question, Birol, for you. With what camera do you see the meiotic spindle?
We are using an oocyte system. So oocyte system at the meiotic spindle with camera, like a special HD quality optic zoom. So it's just a catching with a different different colors, so it's showing us a different filters. So we are getting a black and white spindle visualization. Also, we are getting a color. This is as for me, the high quality technology in the market for the spindle view. And actually, like which I can suggest who want to invest at their lab. So this is the one of the important which they can think to invest to get a meiotic spindle wheel.
Yeah. Can we check that my baby is not sick, remove the genetic disease and choose the color of his eyes? I don't know the name of who is asking this. Actually in IVF, once we are doing IVF, the risk of having a baby with genetic disorders is the same as in the population, but we are having, and we were talking about different options how to avoid or minimize that risk. By doing oocyte NGS testing, we are checking that the oocyte is euploid. We can do also testing of the embryo by doing embryo biopsy and NGS testing of the embryo. So we will tell euploid embryo means this is genetically healthy embryo. So by these steps, we can avoid and minimize the risks to check and to choose the colors of the eyes. This is genetically related thing. Usually, if you want the baby to be looking more like you, and this is suggested by all the doctors, the phenotypical signs of the donors should be the most closer to yours. Meaning, if your eyes are light, the donor eyes should also be light, etc. So if you need to consult on this, you can ask us more specific questions, and we will help you to match the donor and to understand this process. Another question from Carol. Thank you for your lovely talk. Thank you. I would like to know what media is used for vitrification, Kitazato and Cryotop open system.
Yeah, we are using a Kitazato protocol and open system. Also, of course, that there is possibility for the closed system, depends of regulation and depends of request of the clinic. But mostly, like our frozen egg bank have open system cryotop.
How long do you wait since the pickup until the moment you take away the granulosa cells?
So as I said, this is really crucial things. So what we are doing for us really important, like we will avoid the post-maturation and which oocyte will come through oocyte pickup M1 and till to wait the denudation and freezing will be M2. So those oocytes, what I get experience from artificial intelligence, even if they look perfect, immediately artificial intelligence putting them in Q2 categories. So that's why I'm trying to keep that time as OVOGENE, our team, trying to keep that time as shorter. So after the oocyte pickup for egg banking, we are waiting 1 hour then to get the denudation and an immediate freezing. So for the regular process, for fertilization process, in the clinic, we are keeping that time as 2 hours. But for egg banking, we decrease this to 1 hour to eliminate post-maturation and which oocyte coming from M1 to M2.
What might influence embryo collapsing after defrosting? How important is timing between the defrosting and the embryos to embryo transfer? Do you defrost extra embryos just in case there are some that collapse and are not suitable for transfer, or do you want to see if it's okay to transfer or not and then defrost the next one if any collapse? This is from Anja.
Yeah, embryo collapsing is actually it's important for the type of media. Kind of media, like I can give example like a Kitazato, Cryotech, they have high concentration of the equilibration. So that's why when you freeze the blastocyst, it doesn't matter embryo is collapsed or non-collapsed. But when you look other kind of like Vertipro or Vitrolife, so before the freezing, you should collapse the embryo. But the main thing, when you thaw the embryo, if you transfer the collapsed embryo, really you decrease chance of implantation. So that's why after the thawing, till embryo get totally open, you need to wait. Sometimes like this time can be more than even 3-4 hours. But that's all research and publications shows when you transfer the collapsed embryo to patient, implantation rate really dramatically decrease. So this is the main point, and not just only freezing, but of course when you thaw, so you shouldn't transfer the collapsed embryo to patient.
Yes, but we are not sowing extra embryos just in case the previous one will be collapsed. So we saw it's after we are checking this embryo is okay for transferring or not.
Yeah, definitely.
Yeah. Okay, so and then one more, it's probably up to the previous question. The time lapse has that camera The camera we were talking about.
Yeah, this is, as I say, we are using a Nikon model, Nikon time-lapse model 300. So this is connected to directly to two different software. One is the artificial intelligence part, another is Aztec time-lapse microscope incubator. So this three system is like implanted to each other. But of course, like as customer, you cannot find such system in the market because it's developed by not marketing purpose, only by science purpose for the OVOGENE team. So you can find, of course, a camera and time-lapse separately, but when you connect them, it will not work, of course.
Okay, and one more question. It's we already answered, but just to double check, the person has that information. How many hours post HCG do you freeze your donor oocyte? We do OPU in 36 hours after the agonist triggering, meaning HCG, so after triggering, and then we have 1 hour for the bank, right?
Yeah, yeah.
Meaning 37. Do you think this hyper response may affect oocyte quality? It's from Carolina. It's also a great question, and actually we are working on final calculations of our experience, because the experience what is published and different teams, scientific teams, are talking about, are promoting or stating about different things which are related to the number of the received oocytes and their correlation with their quality. I should say that at OVOGENE Egg Bank, we are not finally sure yet, because we are calculating final results of our scientific model related to the number of received oocytes and correlation between their maturation, their morphological evaluation, their blastulation rates, their survival rate, and clinical outcomes. So, but initial feeling is that there is no correlation. Like there is some upper level, and we are talking about this upper level being between 35 to 40, depending on the donor age, on the donor initial options like IMH, antral follicle count, etc. But this is not our aim to overstimulate and to get up to 35 or 40. Our average is between 16 to 21, should say, in different quarters. We are calculating per week, per month, per quarter.
Just I can add that the hyper response, what I find out for my experience, only just increasing like number of quality of oocyte. So actually we didn't see like significant difference between hyper response and normal response for the fertilization rate and blastocyst rate. But of course, still this is not enough data. It's much important to get a clinical pregnancy rate and implantation rate, and also euploid blastocyst rate.
Right.
So will give us a
why it is complicated, because we are calculating cumulative result, meaning if this was an initial cycle where the donor produced 15 oocytes and 35 oocytes, we are willing to collect the data of the clinical outcomes from all oocytes being sought, fertilized, which we got blastocyst, and the clinical pregnancy from each of the cycles. So that's why this is quite complicated in the egg banking, because if we are sharing, like we are putting all those oocytes into our database, and then patients are selecting sometimes 8 or 10 or 12 or more or less oocytes, and we are waiting until all the oocytes from one stimulation cycle will be used in order to get this data for the calculations. How long is needed between preparing a surrogate to be prepared to embryo transfer? It's not really the question to that webinar, but usually as you confirmed your surrogate and you know who is going to be your surrogate, those women are initially tested, they are screened or completely screened. And as soon as we have embryos, we understand this would be your oocytes or egg donation or like material which will be transferred to Ukraine from any other location. This is also happening. The surrogate mother is preparing her endometrium for up to 3 weeks. including if we need some synchronization for this, if this is a fresh cycle, for example, so it's up to 1 to 1.5 months. This is the maximum. Okay, so we have so far, as I see, no more questions for today. It was really longer than we expected. Sorry for that, but I hope it was really important and interesting for you. For us, it is very important to share our experience. We talk with many of you privately, but we would like to talk more, and we are happy to answer any of your questions, and we will happily provide more and more webinars and share our experience, our data, our knowledges, because this is such time, and this era of COVID really educated us a lot of connecting with people so easily, to be so open and transparent, and giving the opportunities to know more about the opportunities which are happening around. And this is true. I'm in egg banking also for 12 years, and these days, as never before, clinics are contacting us and they are asking, are you still doing that? Are you still offering the eggs to be sent to my location? Please do, because those patients, they have age limits, they have complications to travel, but they are willing so much to get pregnant. So together, by doing this together, we as a bank and you as a clinical facility, we can do more. We can make those people happy, healthy, and pregnant. So I wish good luck for all of you, good health, take care, and watch our webinars. We will post very soon what would be the topic of the next webinar and the date. Thank you so much.
Thank you. Bye-bye.
Bye-bye.